Hi, everyone. Thank you for joining us for this webinar, which is part of our series of presentations, which are focused on applying evidence into practice, which is part of the comorbidity project funded by the Australian Government Department of Health and Aged Care. My name is Christina Morell. I'm an Associate Professor and Deputy Director of Treatment and Translation Research and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. And I'm joined by a few members of our team today as we bring you today's webinar, which is being presented by Dr. Eddie Mullen. And if you're able to stick around to the end today, Sally Boardman, one of our new training facilitators, is going to be hosting the discussion session. Before we start, I'd like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting and recognise that we're meeting across Australia today. The traditional owners of the lands that I'm on are the Gadigal peoples of the Eora Nation, and I would like to acknowledge the traditional owners of the lands across Australia for everyone else who is here and pay respects to elders past, present and emerging. I'd also like to recognise and acknowledge the many people with lived and living experience of mental illness and substance use, as well as their families, carers and loved ones, many of whom have generously contributed to the development of the guidelines on co-occurring conditions, as well as our other resources. So just briefly, whether you're joining us live or watching the recording later, you're all in listen-only mode, which means we can't see or hear you. So I'd like to draw your attention to the Q&A and chat buttons on your screen. If you have any questions for Eddie during the presentation today, please feel free to use the Q&A button. If you have any comments or anything other than questions for Eddie, can you please use the chat button? And this just helps us keep track of what questions we pass on to Eddie, or whether there are other requests for support or technical issues that we need to assist with. Both the slides and recording for the webinar will be available for download from our website in the next few days. The link for that is on screen. I will hand over to Eddie in a moment, but before I do, I want to mention that you can access our webinar library and register for our next webinar at the website, and the link to do that is there on screen as well, and we'll also be posting that in the chat. If you have a few minutes at the end of today's webinar, please take a minute to let us know if you have any feedback or suggestions for future webinars that you'd like to see us incorporate into this series, and we'll see what we can do. And now it's my pleasure to introduce our speaker for today, Dr. Eddie Mullen. Eddie is a youth psychiatrist and has been at Orygen Specialist Program in Melbourne for over 11 years. He's the Director of Medical Workforce and co-lead of the Orygen Youth Addiction and Dual Diagnosis Stream and Substance Use Research Group. He has a strong interest in understanding developmental perspectives of substance use from early adolescence into adulthood and how this can inform our approach to screening, assessment, and offering evidence-based treatments, as well as the intersection of youth, neurodivergence, and addiction. We're so very pleased to have you here today, Eddie. So I will hand over to you to get started. Thank you.
Thank you so much, Christina. Thank you for the introduction, and a big thank you for everybody for devoting some time today to come to this talk. I'll just share my slides. There we go. Excellent. Classic. We do it so often, but all the time we still have to work out how to show it. But yes, thank you very much for the introduction, and thank you again for the invite here. As I said, it's very exciting to be able to talk about sort of what this field to like-minded people. As I said, my name is Eddie Mullen. I use he, him pronouns. I'm a psychiatrist by training. I've been working in youth for over a decade now, and particularly down in Melbourne in Orygen. And I've been working mainly in the addiction space, but also on personality disorders. And almost naturally, I've come into this field of working with young people from a range of different neurodivergent backgrounds, and really I've become much more interested in kind of really see a need to advocate and spread the word and talk to other like-minded people in the community to think about how best to help young people and adults who come to us for treatment. Also, I'd like to acknowledge the traditional owner of the lands. I come to you from Parkville, Melbourne, from the lands of the Wurundjeri people of the Kulin Nation, and pay respects to their elders past and present and emerging. So no conflicts of interest for the talk today. So also to acknowledge that the work I do is not just my own interest, but it sort of builds on the work of a lot of people who are very interested and active in this space, particularly down in Melbourne. And I want to acknowledge particularly Professor Sandra Radovini from Mindful, as well as sort of Professor Dave Coghill and Catherine Cox from our own sort of neurodevelopmental team here at Orygen, and also Steve Lester and Rika and Rebecca who lead our youth addiction dual diagnosis stream here. So very much acknowledging what I present is a culmination of a lot of work and interest from a lot of really, really awesome people in this field. So what we're going to talk to today, I think I've done this sort of previously at different settings down in VADA here in Melbourne, but also for the comorbidity guidelines, and really, wanting to talk firstly just to consider substance use and addictive behaviours, and thinking about kind of maybe a developmental perspective. I work with young people, really thinking about the overlap with neurodiversity and what that might mean, and really sort of rather getting too far into the weeds in terms of the evidence space, but really reflecting on some of the challenges and opportunities for those of us who are both clinicians, both of us who work in services, both of us who maybe have lived experience of kind of substance use and neurodivergence, and think about how we might kind of respond to the challenges and opportunities associated with that. Interestingly, I've just come from a conference in Hamburg, the International Society of Addiction Medicine, where there was a huge focus. Actually, there was many symposiums and talks, particularly about this topic, and it's very interesting to see as a field from the US, from Europe, from America, from the Asia Pacific region. There's a lot of people talking about this, and a lot of people are interested, and a lot of the answers, a lot of the questions that are coming are quite similar for all of us. So firstly, maybe a little think about, what do we know so far, really? When I talk about neurodivergency or neurodevelopmental disorders, I think there's a very wide variety of things that we can think about. People, individuals who experience neurodivergence may kind of experience a lot of different challenges. But for the purpose of this talk, I was thinking just maybe narrowing into two major kind of diagnostic groups, for the sake of this, and really is autistic individuals, or those kind of with autism spectrum disorder, and those with ADHD as well. But just to acknowledge that is a very big, broader group of people who experience a lot of challenges and strengths associated with this, but just that we'll now talk about these two. So firstly, for autistic individuals and autism, really just acknowledging that, it is that our concept of what is sort of autism has changed a lot in terms of kind of over the last sort of century, really, and our understanding of something that was seen as a very rare thing that only occurred in childhood, was associated with disability and kind of very distinct from normal development and other disorders, to something that's more of a spectrum disorder, something that's actually becoming apparent as more reasonably common, a neurodevelopmental condition that's present across the lifespan, not just in childhood, as quite often represents just we see a form of normal human variation in terms of kind of development, and it's not just a disorder, but also sort of autistic individuals having a lot of strengths as well that they bring. And seeing that actually when we look at diagnosis, and I think this is something that catches on the media, and particularly sort of in this year or two with what's happening in the US, that's saying that diagnoses are kind of increasing, and what's behind that. I mean, this is something that was looked at a few years ago, but really thinking about maybe our understanding in terms of how to identify people on the spectrum, how to pick up these things early, and how to access the services. Really has been a lot of work done to kind of identify early, and maybe that's led to kind of our increased understanding or picking up sort of people earlier, and sort of that increased diagnosis rate. But also kind of think about, when do we see people, but largely people who might attract an autism diagnosis maybe sort of picked up earlier in the lifespan. But by no means that does not mean that's the only time that we see people. That, especially in my work here at Orygen, we work with young people across 12 to 26 age range. We do see a lot of young people who are maybe sort of have late diagnoses, or some of those challenges haven't been picked up for a variety of reasons, but we're seeing not just childhood, but sort of later diagnosis as well. And also kind of how do we understand sort of neurodevelopmental problems? We know that there is a diagnostic conundrum, but we do that these things do not occur in isolation. That an individual who has a neurodevelopmental sort of diagnosis but picked may co-occur with other things. We know there's a strong overlap with trauma. We know there's an overlap with other mental health disorders and maybe physical disorders. And for the purpose of today, we know there is an overlap with substance use disorders as well. And also just to acknowledge with that overlap, I think we all come from different backgrounds. We all come from different services, from different perspectives. And I think when we're looking at sort of when someone's presenting, seeking care, if there are problems, we've been very aware that needing to take a step back and maybe having a holistic approach about how we look at situations, because we all have our own lens that we look at things from. So really, so being aware and appreciative of that. So autism spectrum disorder itself, just a quick run through. Obviously, by diagnosis, it's a neurodevelopmental condition that affects an individual's development and social communication, and it's present from early childhood. It's just looking at DSM in terms of just actually diagnostic sort of criteria. There's two domains that they talk about. One is that social communication domain, and the other one is kind of looking at sort of more externalizing or restricted or repetitive behaviors. But there's another way to look at that's a very diagnostic way to look at it. If we do look at it another way, that an autistic individual, it's not just a linear thing where you're either a little bit autistic or you're very autistic. That's quite a reductive way to look at things. But maybe also we can talk about that as actually it is a very broad spectrum, so to speak. It's much more than just that linear way that someone who is neurodiverse will have lots of different skills or challenges in their areas of the brain than the average person. And there's lots of different domains that we look at in terms of language, motor skills, perception, executive function, and also sort of sensory sensitivities. Sorry, I'll just pause for a second. And these strengths and challenges is just to acknowledge as well that maybe some of these traits may create some difficulties in everyday life, which lead to the diagnosis of cognitive disorder. But also a lot of these traits that people experience might be useful in everyday life as well. So really is the way we think about it now is to look through things in terms of those are strengths and challenges that people experience. And also just acknowledge the vast difference in the community in terms of the neurodivergent community, that actually if they say that if you've met one person with autism, then you've only met one person with autism. Not everyone who's different is autistic, but not everyone who is from the autistic community is the same as well. And I think it's important to acknowledge those individual differences and also kind of, where do we start in terms of knowing these differences? And that's why the interest, I think, is great in terms of people coming to trainings and coming to talks is how do we get enough skills to understand how to know what sort of autism looks like in different people and, is it the differences between mental health disorders. What are these core features? So speaking about autism, I said I'll spend a little bit of time in this because I think it's just setting the scene. Really, there's some core features that actually consist in terms of the disorder, in terms of those things that we talked about earlier. But also there's kind of a lot of mechanisms or behaviors that also kind of that's I think of developmentally that actually sort of an autistic individual learns how to adapt and kind of and fit in the world, and some of those behaviors are there, and we'll talk a little bit about how they might overlap with substance use as well. But also not to forget, as I said, as the co-occurring side of things that really so the risk is sort of that some individual with autism may experience other mental health difficulties, or maybe even, as I said, other neurodevelopmental issues as well. And particularly that overlap of ADHD is something we're seeing a lot. We're understanding those dimensions. As I said, I think the dimensions we look at as there's many different dimensions. These are some would suggest these are kind of mindful being the one of the major centres down in Melbourne. Teach a lot in this in terms of looking at some of the domains that you might look at a diagnosis in. But moving on from that, really just understanding as well that when we are looking at autism, and as I said, in terms of the lens you're looking at, that actually one of the challenges we face in the mental health service when somebody presents is not to box someone off into a particular diagnosis too soon. Understanding that a lot of challenges or a lot of things that somebody would seek care for may be better explained by their disorders, but maybe sort of not in a rush to make a mental health diagnosis as well. That some of the challenges an autistic individual faces might be overly diagnosed as well, and where do you kind of help understand the person before rushing to sort of clear diagnosis. Some other ones that we talked about sort of in terms of some of the domains, in terms of social impairment, in terms of some of the range of repetitive or restrictive behaviors, some of the sensory issues that might be there as well, and some of the challenges associated with language and emotional dysregulation that quite often, depending on what lens you look at, things can be diagnosed as a mental health condition or might be better explained by neurodivergence. ADHD, just very briefly, I mean, just to touch on ADHD, but we'll just see sort of, I think this might be known to everybody, but just before we get into the substance use disorder, really think about ADHD maybe as a bit of a spectrum as well, but we know generally there's two domains that we look at in terms of ADHD, in terms of the inattentive symptoms that somebody might experience from very early on in childhood as well, and maybe come out in school, as well as similar to autism in terms of these things might present early or maybe picked up later. The two domains being inattentive symptoms and maybe hyperactive or impulsive symptoms, and some examples of how they might look in a child. Something else that we see, and this is something that also that is in the discussion today, is the prevalence that actually it is common in terms of kind of in children and adolescents, 5 to 7% being kind of population, and the prevalence in adults being seen as sort of up to 2.5%. Is the diagnosis increasing in time? You know, sort of what we would say is maybe it's not increasing in time, but maybe that's another discussion we have about how soon it's being picked up and how it's being assessed. What we do know and what we can say is that maybe that actually treatment of ADHD is increasing, and there's been an increase in kind of use of ADHD medications over the last decade or so, and seen across all age groups and both sexes, but maybe more so in females and males in terms of the growth, and one might think that might be a result of sort of increased awareness and maybe increased access to assessment and treatment in the community. As we know, there's a huge need out there. And the importance of, in terms of just very, very much that really why it's important to pick up and why we're talking a little bit about this is really that we do know a sort of a childhood kind of diagnosis of ADHD, or maybe not of sort of missed ADHD, is that sort of those future outcomes can be problematic. And what we want to do is we want to kind of help people avoid kind of sort of worse outcomes later on in life in terms of maybe the association with sort of crimes associated with psychiatric disorder, but also for the purpose of this talk, you know, in association with substance misuse. Thinking a little bit about just stepping a bit back from that and maybe thinking about substance use in young people in general, and just to talk about this is a very area of interest of mine over a long time, and really to differentiate between the things in terminology. And I know these things are sometimes used a bit interchangeably, but really thinking about substance use itself is quite normative in terms of, you know, using things like alcohol or tobacco or even sort of cannabis as prescribed these days is quite normative. But now understanding that, when does that change from use of substances to misuse or abuse, or when, you know, when problems start occurring? When does this actually turn into a substance use disorder, when there is sort of entrenched kind of harms or entrenched disability or loss of functioning related to the substance use itself? But also to say that people do use different substances for different reasons in different ways, and it's important to kind of understand each one by itself. Thinking about just to that topic again about sort of normalizing a little bit that using alcohol or even drugs, maybe even illicit drugs, can be the norm in young people, and there is a bit of a spectrum of use there. And I think this would be no different in somebody from a neurodivergent background, that quite often young people like to use these things experimentally. And people are inherently curious, they love novelty seeking and like risk taking, that often that can also become social, that sort of forming those peer connections and stuff can be a normative experience in youth. And when we start to see issues is that when actually kind of substance use become instrumental, that actually kind of using substances in different ways to manipulate the mood or manipulate affect, to kind of help promote for different types of behavior, or even relying on it for pleasure, and that can become habitual, that actually maybe using things become reliant on substances to cope in different situations, and even to rely on substances to be able to kind of engage in sort of social situations becomes a problem, and then that can result in the worst case in terms of things become more compulsive, and sort of use of substances, obtaining substances becomes a focus of daily life, to the point of dropping out of kind of normative behaviors and stuff. So I think what we do know is that kind of, you know, sometimes the problems associated with substance use is a factor that as someone gets older, that if they start to develop sort of problematic substance use, that that can increase with age, and also the risk of then going on to develop a substance use disorder increases then as well. For my work in early intervention services down in Orygen, I think it really is sort of the area that I work in, the 12 to 26, is an area of great interest, because I think most alcohol and other drug use does start in adolescence and sort of coincides with the peak onset of other mental health disorders and substance use disorders in this age group. And when people do have a co-occurring mental health and substance use disorders, that the outcomes are shown to be worse. Just think about substances. As I said, there's many out there. This is from a website, Harm Reduction Victoria. This is an excellent website if anyone actually wants to go on it, just to shout out for them. But I was thinking there's many things out there. There's not just the legal things that people use, sort of cannabis or alcohol and nicotine, but there's many street drugs out there. And I think one of the things I think would be good to get to this at the harm reduction side is that kind of being aware of different ones. These are some good resources available to clinicians if you're interested, if you're looking for some information to talk about with young people or with adults about substance use, with some good advice about harm reduction. What are the main reasons that people use substances? I'm thinking about this is just in general, what we're understanding is sort of the main reason, as I said, is mainly for fun, that people use substances for pleasurable activities. People use substances for social connection. And the third reason that people use substances in our evidence in young people is to cope with negative emotions. And we do know, as I said before, that that might be associated with developing a more problematic use or substance use disorder later in life. These are the criteria in the DSM. I won't go into these. I mean, these are freely available, but definitely to meet a diagnosis of substance use disorder, you need to have these criteria. But maybe just to flag a little bit about one of the things that is kind of newer, maybe in kind of in my group that I see in terms of young people, is understanding other things outside of just substances, but other kind of behavioral addictions. Things like sort of going on the internet, things like gaming online, or gaming on your sort of gaming on the phone, or sort of individual gaming, things like other illegal things like gambling. Quite often these things, similar to substance use, might be normative for young people or adults in terms of their daily lives. And when does this normative use become problematic? And that will kind of have a lot of relevance, I think, in terms of thinking of sort of the people from neurodivergent backgrounds. So breaking it down a little bit, sort of going into the sort of the main topic of this talk, really, maybe, as I said, I'm going to break things down into sort of two main groups and think about. One is substance use and autism, and one is substance use and ADHD, for the purpose of this. So there used to be this old view of autistic individuals, really, that they would not be at risk of substance use disorders. And that's because the view would be that autistic individuals are more rules-based. They wouldn't break the rules, particularly around illicit drugs. They would have less social interactions, especially in the schoolyard or with peers, so have less of that peer-influenced social gateway, as we talked about earlier, into substance use. And in fact, even if the peers are peer pressure, that means they would be less susceptible to peer pressure because they'd have less interactions and be more rules-based. I see that as quite a reductive view of an individual. In fact, you know, what we know and what people say is that actually individuals with autism are twice as likely to develop maybe a substance use disorder than non-autistic peers. And we might think about why is that. Maybe, in fact, when you look at sort of young people or sort of individuals accessing treatment services, that maybe as high as maybe 1 in 5 teen young adults receiving substance use treatment might have undiagnosed symptoms of autism. What might say, so thinking about that as well, you know, what does the research say? What do the papers say? Even like, you know, some of the papers in the Lancet, sort of the meta-analysis, saying that, you know, we talk about 20%, or we talk about some of the risks, but among those who provided information regarding motivations for using drugs, that autistic individuals are nearly 9 times more likely than non-autistic individuals to report using them to use managed behaviours specifically. So that's quite interesting, not only thinking about the rates, but also thinking about the reasons why people use. Might this be a little bit different? Or already starting to think about, you know, what might be kind of understanding someone with an autistic individual preventive care, what might be those reasons for use? Might be the same, or might it be different to someone without autism? And it might be that kind of, is there a facility of using things instrumentally, as we talked about, sort of individuals described, and this might be the study for the Society for Study Addiction talked about, obviously, so some interviews with with treatment seeking individuals, that maybe they're using the substances to eliminate, control, or reduce autism or symptoms of autism, or even treat comorbid symptoms. So thinking about sort of that instrumental use, you know, kind of are individuals with autism more at risk of using it as in terms of to cope, or even to manage not only mental health disorders, but the symptoms of autism. So thinking about what might be the reasons for autistic individuals, and this might lead to us thinking about, you know, how might we formulate things? How might we kind of describe or build up a story about the person in front of us who's seeking treatment? You know, might be an autistic individual, and these are kind of speculations or hypotheses to test out, really. You know, as I said, you know, everybody's different. Everyone has different reasons for use, but, you know, might there be an aspect of fitting in that, as we said, there's a big social aspect to use, particularly in young people. Is it a way to fit in with other people by partaking in some of the rituals? And I'd say in Australia, we've got very high rates of sort of alcohol use in young people in terms of fitting in, but by joining in substance use does it help you fit in when you feel it's hard to maintain those sort of those social connections. Is there a sense of masking that actually sort of allows you to kind of mask some of the symptoms if you kind of use kind of substances kind of instrumentally? Does it allow you to feel different? Does it allow you to participate in some of those rituals? Does it help cope? I mean, we already know there is a strong correlation between some substances and managing social anxiety. There is a, you know, increased risk of social anxiety in individuals with autism. Does use of substances help manage social anxiety as well? Overstimulation been another thing in situations, particularly thinking about those kind of not only social situations, but kind of understanding other situations where an autistic individual might experience a lot of overstimulation. Is there a reason for use in terms of managing overstimulation? Is that something instrumental as well as an autistic individual might develop? Is there, I mean, there's a little bit of evidence there, but is there a means in terms of kind of, you know, in terms of repetitive behaviors, is it kind of, this, I suppose, thinking more about if an autistic individual kind of, you know, kind of, are they more at risk in terms of, we know one of the pathways into addiction is that compulsive behavior, as I mentioned before, in terms of if something works, we might use it again. Is, say, an individual with autism who might experience kind of more repetitive behaviors, learning that if something works to help manage some of these other things we talked about, is the risk of kind of continuing to use that, is that a factor as well? But also kind of other things as well. Do some of these things. This is something, does it help improve focus? If kind of it's very hard to focus in scenarios where overstimulation is experienced, or there's a lot of other social anxiety or stressful situations, do certain substances, is there also a way to learn how to use it to improve focus in those scenarios? But also kind of similar to even non-autistic individuals, really kind of, just as I said, understanding, is there a positive reinforcement or negative reinforcement actually does learning to kind of manage emotions and using different substances present as well. So kind of when I work with my young people, really sitting down and kind of not only, I think this wouldn't be unfamiliar work to anyone we work with in terms of trying to understand those reasons for use, but then I kind of think about developmentally the young person in front of me, if they have a understanding, if they have a diagnosis of autism, or kind of we're thinking about maybe there may be some autistic traits present, you know, do I need to broaden my understanding to understand the person in front of me by thinking about, are these other factors there in mind as well that I might want to kind of consider and maybe sort of test out in formulation with the person in front of me. And speaking of the behavioral addictions I mentioned earlier, really, and this is an interesting topic. This is quite an interesting topic to me as well. I think we think about, you know, where on the spectrum in terms of you know, sort of gaming in particular, or being on the internet. Really, how does that overlap with a young person, particularly, or an autistic individual? That I see that quite often, if a lot of the the interests, or a lot of the maybe social connections might be there in terms of kind of being on the internet or online gaming and stuff, where it might be the only social connection, or might be kind of a real pleasurable thing. You know, when does that overlap with kind of an autistic individual in terms of kind of the maybe the repetitive behaviors and stuff, and when does what might be kind of a pastime or hobby turn into kind of does an autistic individual experience another level of intensity when kind of exposed to these things, and does that predispose to kind of more of a severe kind of gaming, gambling, or internet addiction? Substance use and ADHD. So this is as I said, I was just kind of at a conference where there's a lot of interest in this, and there's a lot of kind of interest in the field. Really, you know, is there an overlap? And I think this is something that is quite well known, that you know, having a diagnosis of ADHD is a risk factor for the development of any substance use disorder, and particularly what they say is if the ADHD is untreated. What we do know, the other side is true, that actually sort of people presenting for treatment with substance use disorders have increased risk of having a diagnosis of ADHD that may be undiagnosed. Looking at particularly drugs, and some of the studies that are out there, that people with a diagnosis of ADHD are almost 3 times more likely to be nicotine dependent, just looking at that sort of nicotine use, but also 50% more likely to develop a drug or alcohol use disorder than individuals with ADHD. And similar to the other stat that I said, that if you look at of patients seeking treatment for substance use disorders, that there's some of the estimates saying that up to a fifth of patients could be diagnosed with ADHD as well, and may not be. So quite high rates in terms of this group of co-occurrence of substance use disorders and ADHD. What is the association? I mean, I think there's a couple of putative mechanisms behind this, and I think this is a whole different talk. And I think kind of maybe just to think more broadly, I mean, is there something about the syndrome of ADHD itself? Are these inherent features of ADHD where there might be kind of high stimulants or novelty-seeking behaviors associated with ADHD, but also impulsivity itself being a core symptom of ADHD, which both things being risk factors for substance use disorder? Is that inherent to the ADHD? And also, is there a shared genetic risk factor? Is the actual impaired social or academic or work function of having a diagnosed or undiagnosed ADHD a risk factor developing a substance use disorder as well? And similarly to the last bit that we spent a bit of time on and thinking about autism, you know, is there one of the theories being of, you know, self-medication or self-treatment of symptoms? You know, having ADHD itself being we talked about some of the symptoms being feeling quite restless or those type of things. Is there an element of using sort of substances instrumentally to provide some temporary relief from symptoms, and kind of, you know, does that sort of reliance then on using substances to cope with some of the symptoms of ADHD kind of then lead to developing a more habitual use and maybe onto a substance use disorder? And we know there's a sort of when talking about conduct disorder, that kind of there's definitely an overlap there in terms of childhood behavior and substance use disorder. So where to from here? And really kind of maybe I suppose whipping through that a little bit is really thinking about, you know, how do we think about what we do and adapt our treatments and stuff to work with people from a neurodivergent background. Really, number one, on a service level, you know, how can we improve our services? And based on what we've known and what we know about kind of what people want, you know, how do we make sure that there aren't barriers to accessing care for people from a neurodivergent background? I think from the UK, I think, you know, particularly in things with autism, I think it's essential that we ensure that autistic people or autistic individuals have equal access to high quality social and health care that can appropriately support their specific needs. But I think it's quite clear that, you know, current systems are not still meeting this mark. And I think that's from the UK, but I think we can all agree that that's probably our own experiences of working here in different settings that we work in. You know, what is the problem? I think just this is very broadly about thinking about how services are set out, that kind of people, there's very few integrated treatment services out there that people usually present for help or seek treatment. Either they're going to a mental health or maybe an autism specific service that quite often the clinicians or the workforce in those services, the traditional mental health or disability service, feel unskilled managing kind of alcohol or other drugs. That quite often one of the first instincts is to refer out for care, and quite often, as we know, there can be huge barriers to actually getting into other services. That each service you get into you try to refer to presents another barrier to care, and even within those services that on the other side, we rarely screen for these things. I think one of the things in AOD or mental health services, I think one of what my experiences is that we are familiar with working with young people from neurodivergence. Sometimes we haven't had a lot of training up to this point. More recently things are shifting, but that actually what tools do you use? How do you actually kind of screen? How do you assess, how do we think about our treatment settings that we deliver care? We see people in outpatient clinics, we see people sometimes in hospital-based settings, but also kind of, and I hate this word, but failure, that quite often one of the outcomes of kind of our services not been up to mark, because people do drop out of treatment. They might feel they're not getting out of there, and still this culture of failure that when the treatment isn't the one provided isn't meeting the needs, that people do drop out. It seems a failure rather than actually thinking about the other way, is actually what are we doing to kind of adapt our services to provide care to meet the needs of people who are neurodivergent and presenting for care. But what are the things we can do? I think personalization, this is kind of the message. So as I was saying earlier, really, kind of thinking about sort of broad range, really attuning to the individual. And I think getting to know a person and having that time is important. That often a person may present with some kind of challenges, but also there's a lot of strengths. How do we kind of get to know the person and build up not just a narrative of failure or a narrative of disability, but also kind of a strengths-based narrative? How do we know what someone's strengths are too? How do we know if our communication style is really meeting the needs of that person? Really traditional ways of communicating, of kind of relying on phone calls or sending letters, someone from a neurodivergent background, I think, is that meeting the needs? I think in terms of getting a phone call from an unknown number or relying on that, not having the ability to text as well. Having a one-off appointment. I know definitely I've worked with a lot of young people with ADHD, that kind of, not attending appointments or, being late for appointments or missing letters is kind of a feature of having ADHD as opposed to a flaw. It is kind of one of the reasons that people are seeking treatment, really. So kind of how can we adapt our communication styles to meet the needs of the individual? And really thinking about the environment, so even the physical environment, how do we kind of provide a physical environment that's going to work, that not everybody kind of connects with what we have to deliver. Really, so thinking about a little bit more of that, how do we understand the person? So everyone's tools are different. I mean, I'll just give a shout out for this one. This is the Heads tool. This was developed in some of the Headspace centres. It's also been picked up by the College of GPs. I think it's nice because I think what it does is usually we use something similar to this for young people when they present to us. It really is a kind of a broad sort of initial kind of way to try and understand a person, not just through the lens of symptoms or disability, but really trying to have a holistic view, a formulation, so to speak, of a person. Who are you? Where do you live? What are you into? What are your activities? What do you do? What's your social media? What are your gaming habits? Kind of what's your physical health like? Really then thinking about how do we understand your use of cannabis, nicotine, tobacco, alcohol in terms of your life? What's important to you? How does this fit in? How do we understand you as an individual? But also kind of thinking about how does overlap, but maybe then thinking about does overlap if you've had some mental health difficulties or even risk issues. Otherwise, obviously the approach we use, and I think this is one that I talk about quite a lot, and I think we're quite good at doing this in Australia, that our setting or how we kind of engage somebody is not kind of preaching a mantra of abstinence. There's only one way to do this type of care, you have to meet our needs, but very much what we might do, and especially for young people, is harm reduction, really kind of thinking about we want to understand you and we kind of help you do things more safely, as opposed to you needing to kind of give up these things that obviously that have had a use to you, or kind of you're in, particularly in terms of substance use for coping with mental health symptoms or other symptoms. Suggested, really, that I think the most important thing is, before we can recommend any treatment or plan within our services, really kind of thinking about the person, really spending a bit of time getting to know the individual, having some sort of screens or tools that we might use to kind of start to pull out some information is really important. There's lots out there in terms of, there's two different types in terms of AOD screens, but also in terms of neurodevelopmental screens. Maybe getting familiar with a few that we could use that might lead then to kind of a more of a holistic assessment of a person, and maybe really then that integrated formulation, not just thinking about kind of just diagnoses or symptoms, but really understanding a person's kind of life, where they're at in terms of, maybe I suggested a few thoughts that I had, or what's out there in terms of thinking about reasons for use that somebody might experience, and really putting these into account. And then when we are actually thinking about where to from next, planning treatment and what might modify in someone's life, really making that personalized to the person in front of us. The challenges, and I think this is a really interesting one for me, because I kind of, a lot of this came out a lot actually in this addiction medicine sort of conference I was at, that a lot of the settings and treatments, particularly in the addiction space, are based around group work and group meetings. And I'm thinking, if you are a person with an autistic individual, this might be very tricky to get to, especially not having been used to a service, not having met people, having sit in a big group of people and disclose personal information, or being around people and having to be there might be very, very difficult to get to. Or even if you have maybe if a young person or an adult with ADHD, sitting quite still and paying attention and focusing for an hour-long group or a 90-minute group might be quite challenging. So really thinking about, is the setting we're delivering treatment, is group settings there, is it possible to do more individual treatment, to meet the needs of the person? So we're not having treatment failure or fail to attend the group, but actually understanding that it might be quite difficult, especially at the start, to be able to kind of adapt to that setting. But also thinking about the settings, the physical environment. We're saying, this is kind of an example of an office, but sometimes if we're thinking about things like just even sensory sensitivities, in terms of very noisy, it's very bright, it's very uncomfortable, are we providing an environment that an individual who is neurodivergent will be able to kind of more successfully kind of actually feel calm or comfortable and able to sit in and engage in treatment. So that's more about treatment settings, but thinking about kind of our practice ourselves, and this is a whole other talk. And I think if you're coming to the community of practice next week, I think this is maybe where I'll get a chance to talk about a lot more specific stuff about how can we individuals, and I think the onus is on us really to think about, as not only the service, but us, how can we kind of think about things, how can we adapt what we do to meet needs better. There's some stuff, this is very much, as I said, this is stuff that's been developed at us with Orygen, with sort of input from those with lived experience and input from kind of more specialists in neurodivergence, in terms of, how do we adapt the work that we do to meet the needs of the person, to understand, not everyone's going to have the same kind of challenges or strengths, but kind of understanding, how things crowd over, what is to use, not only the setting, but how do we deliver information, how's the language we're using, what's our communication style like? Do we have access to things like sensory tool? I think one of the things I've learned quite a lot in the last sort of few years working with autistic individuals is it's really useful to have kind of sort of a box of kind of sensory sort of tools to help people, that actually having a different range of things you can use in session is important. Using more visual aids, having more things, adapting the way that I actually kind of interview or actually talk, in terms of kind of the structure that I use, to explaining more, kind of being less ambiguous and stuff that I do. I consider my language as well. Really thinking about, kind of trying to be less abstract, more concrete, being more specific and how it be more predictable and more structured about the care. But also really, and I think something I quite enjoy of getting to know my young people is really understanding them and their special interests and their strengths. If they're into gaming, if they're into anime, if they're into specific things, really understanding that and trying to draw off those strengths. The strengths as well. I mean, I think that's think about what people are good at is important. And also, just as I said, the things are very important in terms of, if understanding and asking them. Not everyone has had assessments done, but understanding sensory preferences, particularly in terms of, sort of noise, light, location, understanding anxiety in terms of, kind of coming to a clinic, sitting in a room with somebody, understanding and managing that level of anxiety that might be there. But also kind of thinking about, and particularly in the ADHD as well, in terms of kind of those executive functioning differences in terms of holding attention and concentration, kind of really trying to kind of adapt my treatment for the person in front of me. It's a whole different thing. And being explicit as well, that really important, really, taking a slower and detailed approach. I think I just like that slide, but I understand that I do talk a lot and I'm Irish and we tend to use a lot of metaphors, a lot of stories and stuff, but sometimes really spending a bit of time and kind of being more specific about the context and what I'm talking about. So this is something I'm happy to share. I mean, there's many things out there in terms of kind of some, not all treatment of being a psychiatrist, obviously get involved in pharmacotherapy a bit, but being a youth psychiatrist and being someone who's a therapist as well, I do a lot of psychotherapy or psychologically informed advice. And I think it's useful to, if you have access to any, or maybe even part of this talk, sort of some sort of guidance in terms of how to adapt psychotherapy for young people. This is about young people in ASD in particular, but some of those things I've talked about, some of the specific changes we can do. Thinking about treatment itself, and this is kind of when we think about offering treatment, and I think shifting gears a little bit just to ADHD itself. And I know this is a big area of interest, and maybe we'll get a chance to talk a bit more of this in the questions at the end. But I want to talk more very broadly about this. This is quite a not controversial, but it's an area of a lot of discussion within the field itself, and particularly in psychiatry, that do you offer people with ADHD and substance use disorder treatment, in particular pharmacotherapy for their symptoms, or is it too dangerous, or I don't know what to do. I think there's a lot of range of opinions out there. And what I might thought to do is I might refer this back to the guidelines. So there is a group that the ADPA, which is kind of a body that's been set up in Australia, and really thinking about, when you do look after people with the co-occurrence of ADHD and substance use disorder, that you should probably try and focus on both disorders concurrently, that you should consider the interrelationship between the two, as we've kind of mentioned a bit briefly, and if possible, if there is some guidelines, try and follow kind of best practice in terms of what guideline concurrent care would say for both disorders. Should we do it? Well, I think what we would say, the evidence is there that actually, individuals with ADHD and sort of substance use disorder, do experience, there is a need there. They do experience earlier onset of a substance use disorder. That actually there's a risk of ongoing problems. There's greater risk than those without, once dependent. And in fact, it does impact treatment, that actually kind of having the co-occurrence of ADHD and substance use does reduce remission rates and a longer wait to treatment, and also does affect kind of retention rates in treatment as well. How do you manage co-occurrence? I mean, really, this is the question. If you treat ADHD, we do know that ADHD symptoms will actually, it's been shown to interfere with substance use disorder treatment. I mean, if we want to treat both, but also kind of have ongoing substance use, will limit the benefit of ADHD treatment. So kind of rather than do one at a time, how do we do both together? Is it beneficial? I think it is, and I think this is some stuff. Actually, some of the there's a great group from PISA, and sort of the Minutza, sorry, I spelled that wrong. The group, they were talking about at the conference I was just at, that actually the evidence say yes, that actually if you pick up ADHD earlier on in childhood and treat, that actually there's better outcomes later in life in terms of developing something like an alcohol use disorder, and in fact, sort of treating my childhood ADHD and picking up early actually might be associated with decreased risk of any substance use disorder later on in life, and the future impairment that's caused by, as I said, this interaction between the two. A little less clear, but what the advice is that there might be similar effects in terms of adults with ADHD and substance use disorder treatment, that actually kind of offering treatment for ADHD itself may improve sort of the co-occurrence of both. How do you treat? That's a big question. It really depends where you go to and who you talk to, but very much sort of a multimodal approach is preferred. That actually kind of just pharmacotherapy alone is probably not going to be sufficient. I think for a variety of different reasons, but if you have access to behavioural interventions as well in terms of the substance use disorder, that combining with behavioural intervention or with the working alongside another service would be recommended. If there's specific concerns, and this is some of the literature, the reluctance maybe in the field to treat ADHD and substance use disorder, that if pharmacotherapy would be useful, that maybe a way to do it if there's an active substance use disorder concurrently, particularly methamphetamine or cocaine, like a stimulant disorder. Maybe having a non-stimulant medication, of which there are several, might be reasonable to start off with while things are stabilizing, but maybe that helps us stabilize the ADHD and maybe the substance use disorder. That maybe stimulants, and this is another area of debate, that actually kind of using stimulants in the setting of substance use disorder, in particular stimulant use disorders, might not be as efficacious. But if that's there, maybe longer acting agents might be better or safer to use than shorter acting agents, which is the general advice. How do we decide? As I said, I always try and base myself, is there guidelines that sort of might give us some advice about how to do it? I mean, there's not a lot out there. We'll talk about the ADPAC guidelines as well. I think they're reasonably sensible. They tend to, they're generally agreed amongst a lot of different professionals in the field. So they would be seen as endorsed by many colleges in Australia as an example of how they might have that decision flow chart of what to use. But most of all, how do we work together with the community? And that's quite important, I think, to think about. I think working collaboratively with the person in front of you is key, really. It's actually not being, sort of trying to understand that quite often, as I said before, there's a lot of barriers to care. There's a lot of people experience treatment failure, as in kind of the treatment settings not being sort of adequate to meet the needs of the person. So really putting ourselves as equal, that actually I think we want to understand the person in front of us. We want to spend a bit of time. We want it really to be collaborative, and that's what's going to work. But also understanding, we need to, that intersectionality. It's not only neurodiversity, but just understanding the person that a lot of young people and adults in the community might identify from different backgrounds as well, and being respectful of that intersectionality, and knowing that working together, it's not just one of us, but as a community, as professionals, and working with our patients, with the people in front of us, we'll have the best outcomes. So thank you very much.
Thank you, Eddie. That was fantastic. What a lot of ground covered. Thank you so much. We do have lots of interaction, people very interested, and lots of questions. So I am mindful of the time. We will make sure that we finish on time. But if you wouldn't mind us answering a few of the questions, that would be fantastic. And for those of us joining today, if you're not already aware, Eddie has generously offered to come back next week for a bit of a case discussion. So anything that we can't get through today, if you're a COP, Community of Practice member, we'll have another chance to ask Eddie some questions, and we will, continue the conversations. If we don't get your question answered, please send it through. We'll ask Eddie if he can answer it, and we'll get you the answer. So Eddie, kicking off, there's quite a lot of interest and conversation about getting assessed, getting diagnosed. You've mentioned that ADHD could be a risk factor, particularly when it goes undiagnosed. And so we've got a lot of questions about that, getting that assessment being a potential barrier to appropriate treatment. I'll read you on the questions. How best can we support our clients to access assessments, especially for ADHD, given that many are experiencing significant financial constraints, also very long wait times in various areas, So that's one part of the question. Lots of people agreeing that that's kind of a major barrier to people getting assessed and therefore then treatment. And then further to this, best practice recommendations regarding how long a person needs to be abstinent from a substance before an assessment can be considered.
Yeah, well, fantastic questions, but you know, I think it's wow, it's the top. It really is the big question of the day, and I think kind of it really is a factor of the awareness really in the community that of the need for this case. And I think it's over the last few years, I think people say, wow, there's been this huge explosion in demand for assessments and stuff. And I think that's because there's increasing awareness that of some of the challenges that people face. People are being aware that it feels like there is something more going on that's there. Um, so I suppose broadly, it's kind of I suppose I can answer it in two or three parts really. Really, it is to get a formal diagnosis is a challenge at the moment. I think who could do it has been the rate limiting step. I think if you're under 18, I think traditionally it's been done through pediatricians and through the child hospital, and they still form a huge part of what they're doing. I think psychiatrists have really only come more lately into the space, and I think that's been like this growth and awareness of people feeling they've missed out on diagnosis when they were young for a variety of reasons. I think a lot of people do go under the radar, fall to the cracks, so to speak, for a variety of different reasons. And maybe it was very much limited to children with most of the more severe behavioral problems when they were young who got access to the services. But a lot of people who missed out. And genuinely, yeah, I mean, there's this been big growth in terms of what private psychiatrists do, but we know they're very expensive. There's a real financial barrier there. There's been a lot of online services. And I mean, by no means am I bagging them out, but I'm saying there's been a lot of different services are available to try and meet the needs. But you know, thinking about, you know, are they all sort of the same level that someone would get if it was an individual or face to face and there. So well, I would say that kind of, but also actually very interestingly, and I think it's been a huge development actually in New South Wales, I think opening it up to sort of GPs and the college of GPs in New South Wales, I think really
Yeah.
leading the way in terms of
Yeah.
realizing there's this whole unmet need and that GPs also have a huge part in terms of seeing people in the community and opening up that border and those things there. So what I would say is that I think we only do to the level of what we're confident doing. And I think there's a difference between, I think, understanding somebody's, as I said, formulation of understanding that someone may have this sort of problem, especially in ADHD, with inattention, hyperactivity, lack of focus, has been very impulsive. I don't think we need a formal assessment to really understand how those difficulties somebody might understand, might interact with their day-to-day life, and then plugging that into the formulation of how that crosses over with their reasons for use that they might be using in different ways. I think we can all do that without specialized training or sort of, you know, become, you know, sort of do that with the person in front of us. I would do it like we do this in my service because we work with young people. We use some tools, like we've got a screening tool that's recommended. The psychiatrists that we work with are trained to do more, you know, standardized assessments. But by and large, what I would say is also to the question of, you know, how long does somebody need to be kind of clean from substances to diagnose? I mean, this is like the old debate they had that you couldn't diagnose depression unless someone was not using for 4 weeks. You know, when we realized we're missing out on a lot of people, what we think would be very hard to, given what we've talked about, that, you know, the prevalence or the co-occurrence for someone to stop their use to a point where they're coping enough to get to an assessment. I think that'd be a huge barrier in care. I think what I would always say is I always look for someone who might think they might have neurodivergence to think about, you know, how early did you notice these things? You know, was it in school? Was it primary school? You couldn't see or didn't get in trouble? How might these things might be impacting your life right now and how might be there? So really, even if someone's currently using substances, they would have experienced a lot of these things very early on. So maybe more familiar with being not attentive in class, being very dreamy, being very distracted easy, losing keys, forgetting homework, you know, missing appointments. People would usually kind of be able to tell you they've experienced these things from when they were a kid or somebody, a family member or partner be able to tell you. And it's only more later on when the substance use started. So you wouldn't be relying on just the person in front of you right now who's experiencing the substance use maybe disorder. In ADHD, you'd be able to go back in time and maybe think about things from a much earlier age before the substance use started. So I'd say there's a big need. There's very few services, but I think we can formulate. But there is some good tools out there. Happy to include them and email them as well that you can become familiar with using.
Thank you, Eddie. So much more to talk about, but it is time. So I'm just going to pass back over to Chris to close us out. Thank you, Eddie.
Thank you, Sally, and thank you so much, Eddie. We do have some more questions, and I am aware that am I on the right screen?
Yes.
I'm assuming I am. Good. Okay. We do have more questions, and I'm aware that we haven't got to them all, but people have been so interested in what you've been saying, Eddie. There's been lots of interaction and engagement coming through. But I want to just let everybody know before we finish that you can find out more information about our guidelines, which this webinar series is linked to, and our other resources at our website there on screen. And for you practitioners out there, we have put this in the chat, but we're very excited to let you know our online community of practice, which is also funded by the Australian Government Department of Health and Aged Care, is available, which is new. This is for professionals in Australia who work with people experiencing co-occurring AOD and mental health conditions. And you can find out more information about that through the link online. It's free. You can register for it using the link there and navigate through our homepage. And Eddie will be doing a case discussion with us next week if you're able to join us. So thank you again for having joined us for this webinar. If you're interested in having a look at our library of previous webinars, watching this one again, catching up on anything you might have missed, or sharing it with your friends and family, registering for our next one, you can do this via our website. The next webinar is scheduled for the 4th of July. That will be with Dr. Robbie Fullerton, who'll be speaking about motivational interviewing in the context of substance use. But until then, thank you again for having joined us. Thank you again, Eddie, and please enjoy the rest of your day.